Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Well, welcome everyone to another episode of The Pursuit of Health. I'm your host, Rainier Schur. Joining me again today is Jared Rhodes and Colleen Smith. Welcome, everyone.
Good to be here.
So today we're going to discuss one of our articles again, and this time it's an article by Colleen. I believe it's called The Breakup Medicine Bill Treats the Symptom, Not the Disease. It's on our Substack. And let's just dive right into it. So let's set the basic context for this article. It's in response to a bill proposed by Senators Elizabeth Warren and Josh Hawley on breaking up big medicine. So what's the context under which this bill got proposed? What's it trying to do?
So the bill, as Hawley and Warren have kind of framed it, is an attempt to address the problem of vertical integration or large corporations that are kind of quote unquote taking over medical care. So you can think about this in terms of what we've been hearing about a lot in the news, how pharmacies are owned by insurance companies, also own the pharmacy benefit manager, which also own doctors' offices. So if all of these groups are sort of co-owned under one entity or exist under one entity, they're considered vertically integrated. There are also instances of horizontal integration where, for example, multiple doctors' offices will join together and kind of be owned under one larger medical entity that just does various physicians' offices. But this bill is more specifically targeting vertical integration where multiple different types of medical providers or kind of payers are owned under one umbrella company. And it basically just flat out attempts to divest them of each other. So they just will no longer be able to exist in a corporation under one umbrella. I think it does recognize some issues with these vertically integrated companies, which are that it kind of makes things more opaque. Patients don't really have that much of a sense of what's going on to begin with. Pricing is opaque, rates are opaque, what medications you're allowed to that are covered by your insurance is not always clear. And when all of these companies are kind of making deals in the background, it can feel a little bit like you're being ripped off and they're making deals for their benefit and not for your benefit as a patient. And I think sometimes they are doing that. And so they've identified something that's a real issue. I also think that often these vertically integrated companies are kind of doing things that are a little bit underhanded, a little bit hidden. But I think what we really need to do is ask ourselves, well, how did we get to this point? Like what happened preceding this that allowed these companies to develop in such a way that they are making these kind of backroom deals that benefit them at the expense of the patient and that sort of thing. And also, is vertical integration at root a bad thing? Is it always a bad thing? Maybe it isn't. And we can look outside of medicine at examples of vertical integration that have benefited us as consumers. And I think also benefited the corporations that are involved in that vertical integration in a kind of win-win way. So what I'm trying to argue in this essay is that while I think Warren and Hawley have noticed something that is a real issue and have identified it, they're going after it kind of in the wrong way, kind of from this top-down way, rather than trying to recognize that there could be some good elements to vertical integration. And if we totally just force all these companies to split apart, we'll lose any of that potential good element. And they should be asking themselves what the causes are of this, for lack of a better word, kind of bad elements of the vertical integration that we're seeing, and then really addressing those. And so that's what I wish someone would come up with a bill that does.
And I think what's interesting to point out is that it does make sense why they're going after these big corporations. The affordability of healthcare is a real issue. It's also a big electoral issue. So it makes sense for them to come up with a bill for it right now. And big healthcare corporations do play a big role in our healthcare system. So then it is a reasonable question to ask, what role do these big healthcare corporations play in making healthcare unaffordable? And in particular, for your article, Colleen, and for this bill, what role does vertical integration play in making healthcare more or less affordable? That's a perfectly legitimate question to ask. But then it's also important to recognize what this bill does. It's telling people that you can integrate your company in this way, right? You can have an integrated healthcare corporation, and patients can't go to them, right? So like they're also deciding basically for patients how integrated their healthcare can be. And it's one question, well, first of all, will that actually make healthcare more affordable? And is that right? Like, is it right for politicians to decide how integrated the healthcare of their patients are, especially because integration, as you said, Colleen, does have all these other benefits in other industries where it leads to a smoother experience. The different elements within the system speak more clearly to each other, whereas right now healthcare is very fragmented, right? So in that sense, vertical integration also makes sense in response to the fragmentation of healthcare.
Yeah, I would just jump in and say, this seems to be a bill that is very it's sort of in tune with a national feeling, I think, in some way, and that kind of gets to what you were saying, Colleen, about there being this sense out there that that something is, just too much of the system is like behind a curtain, right? And not operating in a way that is really um, in the interest of patients. That's so they're tapping into that feeling, which and there's something that's like real about that. Um, it's an interesting bill. It's not really quite an antitrust play in exactly the traditional sense. Like it's not, I mean, they do say in all of the press releases and if you listen to the testimonies and the articles that have come out about it, there's a few statistics that that are shared in every one of these examples, like that the top three PBMs, for instance, control 80% of the market, right? That stat is out there and is in practically every piece of media. Um, but and that makes it kind of sound like an antitrust kind of thing, but it really isn't aimed at that. It's really aimed more at the vertical integration part, as we've been saying. It's the various combinations of ownership that they want to label as problematic. And I mean, I don't see how they can kind of get away with coming across as claiming such omniscience, to know that exactly these three or these four combinations of ownership types are exactly the problems here. For instance, they like you can't. This bill would prohibit a parent company from owning a medical provider or management services organization and a PBM. So it's like one of those two or this, and there's multiple like combinations of this that are spelled out in the bill. Um, I mean, what study, what analysis are they, relying on to know exactly that those are the combinations where, allegedly all the problem is coming from? I'm not sure. Um, I would just say that I think they're really kind of tapping into some kind of anger out there, but they're pretty short on a solution, I think, and I think um, they're grabbing for the easiest kind of tool, which is a ban, right? And so that's what we have proposed here.
Yeah, I mean, I agreed. I think they're tapping into something that's real. They've identified a real problem. Um, but they're kind of they're like taking a hammer to it, and they really. So an example of this, I saw one of there's an ophthalmologist who is a kind of comedian. His comedian name is Dr. Glaucomflecken, which is a weird eye disease. Um, So it's kind of funny, but he actually did a short with Senator Warren, which I
Saw
saw.
that. Yeah, yeah.
And she identified the problem with the vertical integration is that they don't have any competition in that short.
Mhm.
And I think she's correct. And so I think the next question, though, is why do they not have any competition? And the reason that they don't have any competition is because of the regulatory and policy landscape in which we exist that has eliminated competition in a variety of ways. Sometimes kind of top down eliminations of competition, but also just they've not made it possible for small providers to survive and thrive in the healthcare marketplace because of the regulations and policies that exist and the way that payments are structured. So I think if Senator Warren and Senator Hawley really wanted to kind of fix this problem of vertical integration and opacity and in the marketplace and vertically integrated companies kind of following money in a way that chases their incentives at the expense of patients, then they should be addressing the underlying factors that have limited competition for these vertically integrated uh, companies. And they're not doing that at all, even though Senator Warren has clearly identified the lack of competition as one of the primary reasons why these companies exist as they do.
Right. I think it's interesting though that, and Dutch Rojas has pointed this out in the response article that, well, it's a bit hypocritical because he points out that Senators Hawley and Warren, in their own states, have made competition very difficult, right? Like no new surgery centers in Massachusetts for how many decades now? CON laws in Missouri, right? So, but I think that is a legitimate kind of criticism. But the danger here is that it's the government that should decide how competitive a market is, right? And the danger there is then you're saying like, well, then they can decide how big an organization is. And I think this focus on size really misses like the real meaning of freedom here. Like, I mean, I like Mac and my iPhone and like they're all connected to each other. Um, I like these big organizations and I like buying products from them. And I just because they're so big doesn't mean that I need some senators now telling me that, well, no, we need to break them up because we need to allow smaller competitors to be able to have a chance. Is that, well, in this particular market, the reason they're so big is because they're so successful. So if they're able to be so successful because they're able to please customers, then you can't hold their size against them, right? Their size is signal that they're serving people. But I I think that's not the case in healthcare, right? And why is that? Well, because it's not just that it's not a competitive market, it's because you can't compete because of all the regulations, right? There's regulatory capture that the big organizations take advantage of. And that's not the case for something like Apple. Like I could go to Android or to like some other kind of platform.
Right. Yeah, I think you hit on something really important there, Ray, which is that there almost aren't options for patients to go to other places. They're smaller healthcare providers, and when I say provider, I say it kind of in the sense of the Howley and Warren bill, which is kind of inclusive of uh, doctors, offices, pharmacies, kind of any kind of consumer end provider of healthcare. So not just I'm not trying to refer to providers as doctors and physician assistants, right? So so producers of healthcare. I think that the smaller versions of that, small physician-owned hospitals, farm like neighborhood pharmacies that are owned by the pharmacist, those entities struggle in this marketplace because of for example, this is just one example, because of the way that they're paid. They are paid significantly less than larger hospital corporations that are more vertically integrated are paid by Medicare and Medicaid. Like the reimbursements are just much smaller. And they don't have necessarily the bargaining power that the larger corporations have to bargain lower rates with health insurance companies either. So those smaller entities, they're closing down not because patients haven't chosen them. They're closing down because they can't survive. And so like this is kind of a policy and regulatory choice about how we're paying people, how we're paying producers of healthcare that's resulted in a lack of competition for the large vertically integrated corporations. Because patients don't have the choice to choose something else.
Yeah, I think that is really the key here, right? Because in the bill, they talk about how these big corporations are steering patients to more costly and unnecessary options by referring them to their own internal services, right? And that points to like a real experience that people have. Like I'm on my wife's health insurance through her employer, so I don't choose my own health insurance. If like they decided to vertically integrate, I couldn't choose who I would see, right? Or like it would be very limited. And I resent that not because I resent vertical integration, but because it's not up to me, right? And I think so much of this would be different if the patient were actually the buyer of healthcare, which in most cases is not the case because of employers sponsored health insurance, government sponsored health insurance, and all the ways that insurance is the way that most of healthcare is being paid for. So all the regulations that say that like this is what an insurance product should look like determines who you can interact with, and like it's really that steers you this way and that way. And the ideal should be that I get to steer different businesses to me, if they're vertically integrated or not, but that it's up to me. But th this bill doesn't do that, right? It was already the case before this bill that patients weren't the primary buyers and couldn't steer particular businesses to them. And all that this bill will do is give more of the illusion that, okay, well now at least I can shop around between the insurer and the doctor and this and that, but you're still being steered all over the place, right?
Mhm.
And so it doesn't actually free you up.
Yeah. The steering is one part of it. The other thing that they talk about in their fact sheet and their explanation of the bill is the price setting, which is interesting because, for instance, they complain that well, if you've got a system where the health insurance company also owns the physician practice that you're going to, well, now the physician practice could charge you a high fee for the services that you're getting there, and no longer do we have the sort of the check on that, which is normally the health insurance company would push back against that and maybe like do something with networking or something, but they would be the check on that normally. But if it's all the same company, then the insurance will play along like they don't have a problem with the high price for a service because they know that they can also then pass that along to the patient. Um, and the consumer, let's call it at that stage of the game, because the consumer doesn't have much of a choice in who they're buying their health insurance from. So they're sort of getting to like the price component of that, the sort of price setting of that as well. That's another part of this. One thing that I was kind of stuck out to me though is that idea of like what prices are is kind of strange. Because I mean I guess what they maybe have rightly noticed is that in healthcare we've got a system where we don't really have meaningful prices on anything. You can kind of make up your own prices to some extent because but that's not a result of some market putting us in that position. That's something that has evolved given the constraints that we put on the market. that we have a system where, for in this example, like a physician practice can put a high price on on a service, and the health insurance company is not doesn't have any incentive to push back on it because they can always push it along back onto the consumer. Um, in normal cases, people who get to set prices, they get to, yeah, they get to set the price in sort of a um, I don't want to say a trivial sense, but they get to set prices, but it's always within some range because they're working in a market, right? Like yeah, the grocery store down the road can set its price on, what it wants to charge for a gallon of milk, right? But it's within a range, right? Like if they suddenly decide to just run an experiment and charge $50 for a gallon of milk, it's not going to go very well, right? Like they can't do that. I mean, they can do that in the sense of they can change the price on the price tag, but it's not going to work out for them, right? They can, their fluctuation, their range at which they can, play with prices is like probably a few dimes in either direction, up or down 20 or 30 cents, and before people notice and things change, and that test doesn't work out for them. But healthcare, because of how we've set it up, doesn't have those checks and balances in it. Normally, in a functioning market, we would see those constraints be in place, and that would make things work a whole lot better than they are right now.
Yeah, I think it's interesting that when people see the ability of a big corporation to quote unquote set prices really high, their immediate reaction is that, oh, they're too free to set prices. Whereas my reaction is, well, if they can get away with it, do we really have a market? Right? Like, I think that's the kind of question that like pops out to me. And I think this points to like a deeper problem where people think that in order to make things more free, we need to give the government more power, which is what this bill is. Like this bill gives the government more power to determine how integrated a healthcare corporation can be. But I think whenever you have a situation where the government is claiming to make you freer by giving itself more power, it's time to check your premises.
What I think is an interesting example of what Jared is talking about with the price setting that's been going on outside of healthcare, but it's kind of been in the news, which is Instacart. Instacart doesn't own any of these grocery stores, but they contract with the grocery stores to create this platform so the grocery stores can come and like put their products there, and then people can buy them and get home grocery delivery because everybody likes getting groceries delivered to their home and not having to go to the store. And recently, Instacart has been playing around with, they have all this online data that they have on everybody. And so maybe they can charge people who they think can afford to pay a little bit more based on their online shopping presence, a little bit more money. So mark everything up by 10 cents or 50 cents, and then they can keep that difference. And, they probably did this for a month or two, and people have noticed. And people have been like, that's not okay. What the hell? So the Instacart is kind of having to answer for this, and there's a reckoning going on right now. And I think, kind of a similar thing happens in healthcare where healthcare providers are like, well, if we just charge a little bit more, like insurance companies will pay a little bit more. So we'll just keep charging a little more because, and it kind of goes unnoticed in a way that the Instacart fiasco doesn't, because the insurance companies do pay a little bit more. And it's so many steps removed from the money coming out of my pocket as a patient that I can't follow that chain back. If you compare these two sort of in differently integrated but kind of integrated systems, you could see in one case, in the healthcare case, it's been sort of like rolling like a snowball, prices getting higher and higher and higher, and it's like kind of hard to notice because it's so far removed from the consumer. Whereas in the Instacart case, like they tried this thing for a few months and everybody noticed and everybody was like, this is not okay.
I don't remember the Instacart example, but another example like that comes to mind. Wasn't there something recently with where people were kind of pushing back against something that I think it was Uber. They thought Uber was sort of noticing patterns in times that you would need that you'd call for a ride, and people were theorizing that it was noticing, and maybe correctly, maybe not. I don't know. But they were noticing when people like needed a ride to get to work, and then they would like raise the price on that. And then people were like interpreting that as like, oh man, that feels kind of exploitative. You know that I need to go to this place, right? And so, but anyway, whether you think of that as exploitative or not, or whatever, what's the check on that? The check on that is that we also have Lyft and we also have like other alternatives, right? But if if to use the break up big medicine act mentality and apply it to like the Uber thing, the break up big medicine act mentality would be to say, oh well, let's like put a rule against Uber about like how they can do their pricing or something like we'll outlaw that practice or something. But what's better? Is it better to have that rule in place and now that's like another hurdle for people to have to work around, or is it better just to allow competition in this case, like make sure that there aren't any, barriers to entry for a company, an alternative like Lyft or something. And then Lyft has every incentive to not do that and to be known as the place that doesn't do that. Therefore, if you feel strongly about that one way or the other, and you want to, vote with your feet as a consumer, you can. It's two very different solutions to that problem. And needless to say, I think we all like the latter solution a whole lot better than the regulatory solution, right?
Yeah. Lyft then does things like offers a 10% discount if you use them 4 days a week for travel to work or something.
Right,
So who do you pick? And
right.
and then Lyft gets more business, so they actually make more money from their 10% discount.
Yeah, I think that w whenever in these kinds of situations you have this kind of reaction where, oh, we should ban this thing, it makes me think, do they really care about the consumer or do they just really hate this big organization, right? And I think I can't speak for everyone, but definitely some people hate the big organization more than that they actually care about the experience of the consumer. And they'll say that, oh no, like I just care about the consumer and like this will make things easier. But how? Will this actually make them more free to choose care that's affordable to them?
Yeah, and for me, that's when the little voice in the back of my head, that's like the public choice school of economics comes in and says, think about like what incentive the actual individuals of the Senator Warren and Hawley in this case, like the actual policymakers, like, well, they need to get reelected. Okay, so like what plays better? There's a certain political science angle to this where it's like, well, you can probably get more votes and more support by one approach rather than let's vilify the big companies and take them down. We'll be seen more as standing up for the little man if we do that, if we go that route, as opposed to if we try to solve this problem the way that we're all talking about, like what vote do you get that way? It's diffuse. It's hard to measure. It's hard to know if you're like actually gaining votes that way. Like what political point have you scored? It doesn't add up quite as much, and so it makes this other approach, I'm afraid, unfortunately, more sort of politically rewarding to do. And that's poli science, but that's part of the context too, unfortunately.
Well, but some of the things that we're talking about that they do come off kind of as more boring. Repeal certificate of need laws. What even are those? Make health savings accounts available to people so that they can choose with their own money. How boring is that? Like promote site neutral payments. What even does that mean? But honestly, like those are standing up for the little man, making it possible for the little men to actually succeed in the healthcare marketplace. That would be repealing certificate of need laws like the radiologist and his friends who want to start a low cost MRI, cash pay MRI business can just open one because everybody wants to know why their knee hurts and right? Like, and they're willing to pay $150 for the MRI that with insurance they're somehow getting charged $2,000 for. Um, right? Promote site neutral payments. Medicare and Medicaid should just pay the same thing to everybody, no matter what the company it is. Like all of these extra little incentives that get added on make it impossible for your neighborhood pharmacy to operate, make it almost impossible for a small doctor to accept Medicare and Medicaid. Like the message coming from Medicare and Medicaid is really like, if you read the money, we don't want small doctors' offices to operate because we're not going to pay them to. We're paying the big hospitals to operate and take our money. So like yeah, I just think it does come off across as more boring, and there are a lot of little things that need to be changed. So it's kind of harder to create kind of a mass movement behind it and gain the political capital with those things. But if you really want to stand up for the little man, then really you should be like creating a regulatory landscape where they can succeed. And right now they can't. That's why we have doctor shortages.
So one more take from this kind of poli sci angle. I actually think that the issue isn't necessarily that the hard work is boring and that um, going
Mm.
after corporations is actually, I mean, that might be an element of it, but I think the core issue is actually it's easier to tear things down than to build something up, right? Or put a different way, it's easier to operate within the status quo than to challenge the status quo, right? And what does this bill do? It seeks to tear down big corporations. And how does it do that? By putting in yet another regulation. Well, that's the status quo. Like that's kind of like how we got
Mhm.
to
Yeah.
this place to begin with. It's like putting all these regulations on providers, big or small, right? Which is what fuels consolidation, right? So, um, and it's just another instance of the status quo, and so it's easy. You're not actually challenging people, but actually challenging people and building something up that takes hard work, right? And yeah, and maybe also includes some boring work, like technical work. But it's mostly hard work because you're actually asking people to imagine a different way of interacting with each other. So on that note, let's if the ideal is for patients to have more freedom to steer businesses to themselves rather than to be steered by politicians or regulated corporations to particular businesses, how do we create that?
Well, I mean, I think we mentioned a few things already, kind of as we've been talking. And in my article, I list, I think five or four or five things, but there are so many more. I just picked a few, because I didn't want to overwhelm it. But some of the things I've already said, site neutral payments. So regardless of what company you work for, what corporation you're under, whether it's a large hospital system or a small private practice of a few doctors, you should be paid the same thing by Medicare and Medicaid. And I think we should be repealing all of the laws. There are certificate of need laws, but there are other laws that are similar to certificate of need laws in a variety of states that limit the development of new small medical facilities of various kinds, pharmacies, physical therapy centers, hospitals, what you name it. Those should be repealed. We should be allowing physicians to own hospitals. I think people argue that brought up costs, but these physician-owned hospitals, some of them were very specific, like orthopedic hospitals or spine centers, things like that. And so, like, yes, in some way that doesn't kind of promote the bigger landscape of general healthcare, but also it provides kind of these unique areas of competition. And unlike what we have today, those hospitals, their reputation mattered, and now reputation doesn't matter so much. And so it can be difficult as a patient to find what you feel like is a good doctor. And also, that what makes a good doctor for one person is different for someone else. And kind of having that choice, I think, is really important. And it would increase competition, which Senator Warren identified as one of the major issues with vertical integration. Um, what else do you think, Jared, Ray? What other things should we change?
Well, but just to like tie up all of those suggestions, which I think are
Yeah.
all great, what they're all trying to do is kind of change the formula for how you get bigger in healthcare, right? Because getting bigger means being successful. And what it's trying to get rid of is trying to base the formula of success not on regulatory capture, but on providing value, right? So it's as a kind of like reform philosophy, we should get rid of all of the regulations that reward corporations for getting bigger through regulatory capture. And we should create more freedom for corporations to get bigger by actually providing value to patients. But that also means addressing the patient side, right? Which we've discussed before as well, is that we can free up the providers all we want, but if the patient is still not the primary buyer of healthcare, then those corporations and providers aren't going to primarily cater to us. They're going to cater to whoever else is paying for the healthcare, which is the government or employers. And really, what they're really catering to are the regulations and rules under which insurance and other healthcare products can be sold. That's what they're catering to.
Yeah.
So it's kind of a two-pronged attack, right?
Yeah.
We both need to free the producers and free the consumers, the patients.
Yeah.
And I think when we say kind of free the patients, what that really means is patients have to start paying for things with their own money, and that's scary to people.
Hmm.
But I also think we would likely begin to see costs come down and a market that sort of re-regulates itself if that were to happen, especially for common routine types of care.
Yeah, I mean, the problem is that healthcare is already scary enough as it is. And so it might sound very scary to expect patients to pay for things directly, which, by the way, doesn't necessarily mean that they have to pay for particular services. It could just also mean paying for subscription model things that provide a whole range of services. And it is understandable that people might think like, well, you're crazy. Well, that's because prices currently are crazy because we don't have a real market, right? So those things long term would definitely change. So I wouldn't want anyone to think that like, oh, like I have to start paying for everything like tomorrow in this market. Are you crazy? It's like, no, like this is like a long-term project. And
Mhm.
long term, not only would prices come down, but you would have more say over what kind of corporations and businesses you deal with because you control the money yourself. You're voting with your dollar.
Yeah, I mean,
Yeah,
what we have today is like that grocery store that's marked up milk to $50 over and over and over again for years. And like nobody knew that was happening. And all of a sudden now we realize it happened, but how do we get back?
we've created some sort of I don't know, milk purchase card or something that you pay to be a member of, and then that's taken out of your I don't know, out of your wages without much transparency or something like that, and you just gotten kind of accustomed to this whole thing. Um, you both talked about like a two-pronged attack with with freeing the producers as well as the consumers. In a sense, it's like an infinite prong attack, right? Because that's really that kind of covers everything when you talk about producers and consumers. Those are the two, between those two things, that's the whole universe of players in this, and it's why when we start to dissect an issue like this or a bill like this that's problematic, and then we start to name the things that we would do instead, it almost becomes hard to stop, right? Like sometimes there's like one or two things that you can say, oh, if we just fix this it addresses this particular thing. But this is a kind of issue where you could probably name a dozen different things. Colleen, you were great to limit yourself to just five in your article, right? Because you could have gone on and on. And there's also the question of like, well, how finely do you chop these things up? Because some of them become like overlapping in various ways, or they address the same thing but at a different stage. And so, do you call that two different solutions, or do you call that one solution with like a stage A and a stage B or something? Um, but I mean, there are a lot of things to focus on. One thing that's probably going to be high on any list is rethinking the health insurance component of it. Um, all these things are interconnected. It's like a Rube Goldberg machine. If you sort of put one thing out of calibration, the whole chain stops. But there are, I think you can still say that some things are slightly more important than others, and health insurance is the way that we have such an encumbered system where you really don't have free entry into that, um, because of the nature in which it's divided up by the states and everything, and each state having a lot of mandated coverage benefits and its own insurance commissioner. It makes it very hard for any new competitor to come on the scene and like really compete, not for any market reason, but just because it's hard to satisfy that many different regulators, in so many different markets. They can't really compete on a national scale, which makes it that's a protection for incumbents right there. So just one more thing to add on to the list of things that we'd love to change in order to to address some of these real concerns that we've mentioned, and that we agree that there's like a real frustration there, with that Hawley and Warren have identified.
Yeah, I think, like you said, Jared, I mean, there's so many different solutions to focus on, but I think the real work is in people rethinking certain expectations, and also like how they just approach when these kinds of problems come up, right? Like, so often it seems that when a patient feels screwed over by a corporation, they just assume like, well, like they're just doing that to screw me over because they'll make more money, and maybe that's true in like a very narrow sense. But my reaction to that would be, I expect there to be people out there that can provide me real value. Why aren't there more of them, right? And like, how is it that if we are getting screwed over, so many people can get away in a market by screwing patients over, right? Like, if you had that in an actual competitive market, right? Like, if you had a very crappy Amazon that like never delivered your stuff or was always late, it's like they're gonna go out of business. How can it be that there's so many businesses in healthcare that leave patients dissatisfied, that they can survive? Like, and then you actually go to the root causes, which is that, well, like they're actually being told like what kind of things they can sell under what terms, and therefore it feeds only big corporations, and therefore there's no competition. And most importantly, the patient themselves is not the primary buyer of healthcare.
Yeah.
Patients would have to be claiming, let me be the buyer of healthcare, but that's not what we're seeing as much in healthcare. We're seeing it in some areas, like for prescription drugs, where there is more of a call to, hey, let patients be the buyer. But we're not seeing that as a cultural change throughout the entire healthcare system. I think that's a good note to end on, and we'll do more of these in the future. With that, thanks for listening. Till next time.
Till next time.
Till next time.
To stay up to date, subscribe to our show from whatever podcast platform you're listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.